Hey y'all, it's me, Dr. Sameena Rahman, Gyno Girl. Welcome back to another episode of Gyno Girl Presents Sex, Drugs, and Hormones. I'm Dr. Sameena Rahman. I'm a gynecologist practicing sexual medicine and menopause care in downtown Chicago. I have my own practice that is now being converted to a concierge model, and it's going to be called the GYN and Sexual Medicine Collective. That is GSM, because I like talking about GSM on this podcast. Hopefully you guys that are with me can continue to stay with me, or if you are looking for more specialized care, then come to me in Chicago. I'm also in the process of completing a book that will be coming out soon, and I have a lot of projects going on. But today I had reviewed this article yesterday that came out on JAMA, and I was like, oh my God, Chailee Moss, I have to get you on the podcast to talk about it because it's so awesome. We're going to talk to Dr. Chailee Moss, who's a gynecologist that I love from, she's in the DC area, but I have met her through ISHWSH, of course, the International Society for the Study of Women's Sexual Health. But anyway, we were going to talk about her article. You guys hear me talk to different patients and about different conditions, and many times patients are told a lot of things because we didn't understand. A lot of clinicians didn't understand what was happening with them when it comes to their vulvovaginal pain, their sexual pain, their vestibulodynia, their PGAD, their genital pelvic dysesthesias and abnormal pain sensations. So sometimes you hear that, the biggest thing for them to do should be just to relax or, have a glass of wine. And for us, it becomes this thing where like, okay, yeah, of course you were told that. Although in other professions, like we talk about today on this podcast, like people are super surprised that patients are told this. But we call this really a testimonial injustice, where you actually don't believe the patient or really, some people refer to medical gaslighting as in these terminologies as well. So we're going to talk about this new article that came out in JAMA that Chailee Moss was a lead investigator in. And so who is this amazing Dr. Moss? She is a gynecologist specializing in vulvovaginal disorders in Washington, D.C. She first became interested in vulvovaginal disorders at the University of North Carolina, Chapel Hill. Woo, woo. I was also at UNC Chapel Hill, which we discovered that we have that in common. For medical school, she engaged in research on pain and gynecology surgery during her residency training in OBGYN at the Ohio State University, where she was chief resident of education and earned awards for her research in clinical care. When she graduated, Dr. Moss joined the faculty at Johns Hopkins, where she continued to research pain and published original research in this area. And she's a board certified with the American Board of OBGYN and has been an active member of a Society for Academic Specialists in OBGYN, serving on the research committee and paper award committee. She now works at the Center for Vulvovaginal Diseases with Dr. Andrew Goldstein, Dr. Jill Kraft, who I've had on this podcast before, which is an amazing group of gynecologists that work in the DC area, also in New York. Anyway, she is amazing. In her spare time, she travels with her husband and her 3 energetic children in Baltimore, Maryland. So I hope you guys enjoy this. We review this amazing article that really validates what we hear so much. And so let's get at it. Hi, everyone. My name is Dr. Sameena Rahman. I'm Gyno Girl. Welcome back to Gyno Girl Presents Sex, Drugs, and Hormones. And today, hot off the press, you guys heard the intro. I'm so excited to have Dr. Chailee Moss here. We're going to talk about this amazing article that came out that is so important for so many reasons. We're going to talk about all of them. But welcome back to another episode of Gyno Girl Presents Sex, Drugs, and Hormones. I'm Dr. Sameena Rahman. And you guys heard my intro. This is amazing Dr. Chailee Moss. Yay! It's Dr. Chailee Moss!
Well, thank you for having me.
Yeah, I actually we met a couple of times at ISHWSH, but we've never really had any extensive conversation. I know you obviously because I'm friends with Jill, and Andrew Goldstein always talks about how amazing you are. So I'm glad that we're actually getting a chance to connect one-on-one, and the work it was so amazing with the Center for Vulvovaginal Diseases, and it's so important. And this is so important. But Before we get into it, I want you to tell the listeners, like, what got you into vulvovaginal medicine and sexual medicine,
Yeah.
right? All come at some like circuitous routes. And so I'd like to
Yeah.
know, like, what inspired you to become, and to come into the space of vulvovaginal disease and sexual medicine.
Yeah. I mean, I came to it as a patient, and I think a lot of us do come as patients, but I was,
What is this?
I- yeah, yeah, there you go. Yeah. So like I, struggled for a long time, saw lots of healthcare providers. I mean, a lot less than many people see, to be clear, but still have people,
A little bit better.
right. And
A little
but I
bit.
was a medical student still with like very little understanding of what was
Yeah.
happening. And it wasn't
Yeah.
until I was in medical school that I truly got help. And the person who helped me was at UNC, which is where I was at med school, and University of North Carolina, Chapel Hill. And she,
That's cool too.
yay, go.
Okay.
I can't say go heels because my husband went to see.
Well, so this is my dilemma, right? Because I went to Duke for college,
Oh, you
and then I
did?
went to
What?
UNC for med school.
Yeah.
Yeah,
So
because I'm from
he's,
North Carolina.
yeah.
I'm from North Carolina originally.
Yeah, so he also went to Duke undergrad and then went to UNC for law school. So we have like,
Oh, yeah.
he can't really be that mad at me because he also went there for grad school. So,
Well,
um,
and so we don't have a root for the Tar Heels, and you guys that listen know that I don't root for the Tar Heels, but I love
right.
UNC Medical, and I love University of North Carolina,
Same.
and I
I
love
know.
North Carolina. It's North Carolina. Are
I
you
know.
from like, area? Did
I
you?
do not, but my family moved there while I was in college. And so after college, I came down to North Carolina. I actually taught high school through Teach for America for a couple of years and then went
Yeah,
to
yeah,
med
yeah.
school. Yeah. Yeah.
Oh, wonderful. That's the opposite because I grew up in North Carolina, and then my family moved to Virginia when I was in college, and you're
Oh,
in the DC
all
area
right.
too.
Yeah, yeah, yeah. It's a
Yeah,
very nice
well,
area.
it's
Yeah,
interesting. Well, so you
yeah.
were at UNC. So we
So I
should
was at
talk about.
USC. This woman named Jenna Zolnan, who's amazing. She
Yeah,
helped me.
yeah,
Yeah,
yeah. She
and
was there when I was a student too.
yes, and she was just this very you know, supportive mentor who said, "Look, nobody's doing this work. We're out here doing case reports because we don't even know what direction to go in with our bigger studies. How about, if you ever want to do any of this stuff, I'll put you on a case report. We'll do a paper together," which we did. We published a case report based on some work I did in med school. And then I went to residency, OBGYN residency. And, I mean, even on my clerkships, again, love UNC, but I was in a clerkship in a more rural location. And I remember saying I was interested in patients with pain condition and being looked at like, I had horns growing out of my head. Like someone
Yeah,
told me, you don't want to do that. That's
okay.
not what you want to do.
Yeah,
And those patients are too challenging and it's really hard work. And I would never want to do that. Someone told me that. And,
yeah,
as your young, impressionable medical student, in my head, I was like, wait, but I was one of those patients that you're talking about. But
right.
also, like, I don't know what's out there in this specialty. And I'm just going to file that away and kind of go on with my business. But it was a little bit of a deterrent having someone
Yeah.
say that to me. So in
Well,
residency,
I'll just interface by saying
yeah,
that, like, our system is set up to fail patients with vulvovaginal pain and sexual pain and menopausal
yeah,
medicine because, and I say this on this podcast a lot, like, we were expected. I've been a general OBGYN, but before 11 years ago, I was
hmm,
practicing general OBGYN. And, you're in a system, I was in an academic system where you had to see 30, 40 patients a day. And the truth be told, like, I still think about those patients where, you're running around doing obstetrics and you're thinking, I have to go there, I have to go there. And, and you're leaving the room and someone says, but, I have this pain, Dr. Rahman, or, Dr. Moss.
yeah,
And a lot of it is our own discomfort. And I feel like it's like, this, especially vestibulodynia and all the data we have is like what, from the last 10 to 14 years, right?
yes,
This is not something that, like, and I graduated, medical school like 20 years ago. So like it wasn't anything that we had to learn, but like,
no,
so it's just like you had to learn it after. And the reality is, a lot of clinicians don't have the ability to do that in their situation. And so there are ways, I
mhm,
think, to handle it better than the ways that we hear about on this paper,
right.
which I'll talk about. But unfortunately, it's like it's a system issue too.
And I think now that I realize is that the reason those patients are hard, especially in, 2000, whatever that was, when I was talking to that person,
Yeah,
is we didn't have the expertise or the time. Like you talked about, like not having the time to spend with patients and also not having the knowledge to know what to do. And I think those are the two most important ingredients in figuring out these pain problems. And the time is not there in training, certainly. And for a lot of clinicians, it's not there now. And however they want to structure their practice, they can't keep the lights on if they spend enough time to figure these things out with patients. And
absolutely.
so I think that's what I was getting from that person. But what I heard is like, that's not a good idea.
Yeah.
And so in residency, I studied pain. Like I was still interested in it, but I studied it through the lens of like what medications we should use to treat people's pain for surgery. So
Yeah.
I did, and we're in the middle of the opioid crisis in Ohio, and so seeing a lot of people who are getting prescribed big amounts of opioids for minor surgeries, and like, okay, just trying to figure out what are we prescribing, what should we be prescribing, and I carried that work into my post residency work, and also did some work with like colposcopy and abnormal pap tests, and then, got reconnected with Andrew Goldstein and Jill Craft through Golfa Yagdi, who's still at Hopkins and does a lot of vaginitis research. But she knew those guys from GW and she introduced me to them. And so I spent some time with them and reconnected with, something that's always been of interest to me. And what I now realize is that anytime there's something that people are like, oh, who wants to study that? Or, oh, that's really hard. It's like an opportunity because there's such a dearth of knowledge, right? People stay away from it because we don't understand it. But that means there's like so much to learn. And I think
Exactly.
that is, what sort of lights me up about this stuff.
Yeah. And I think that's the important one before we talk about the study is that so many of the patients that talk about their issues and how they were spoken to, like a lot of it is the fact that we didn't study it because we don't take women's health and women's health issues seriously enough, that we weren't researching women's health and certainly not sexual health or vulvovaginal health. It's going to be obstetric health. It's going to be, things that are related to reproductive capacity and those kind of things. But I feel like in the pain world, and women's pain and sexual pain and menopause, all of that is just like the least of, the researched areas. And if it weren't for like centers like yours and, ISWISH and ISSVD and all these organizations, I mean, we're the ones pushing for the research, right? Like we're the ones who are taking care of the patients, or asking the questions.
Yeah. Agreed completely. Yeah. Yeah. I think it's also, we've been thinking of it like pain research, I think has traditionally been like in terms of like directed towards like a utilitarian focus. Like we got to do what these people need to like get them back to work and like just get them to be members of society that can do whatever they need to do. But it turns out if you can't have meaningful sexual relationships, if you have vulvovaginal pain, they profoundly affect the other areas of your life. So it's not like we can say this isn't utilitarian work. It's profoundly impactful.
Absolutely. And so many times it's even life transformative and life saving in so many ways too.
Absolutely.
Especially the ones, not only, obviously like things like elderly women with genital urinary syndrome, menopause, we talk about as life saving, but, people on the precipice of like doing something to themselves because they're living in, right?
Yeah, people who have persistent genital arousal syndrome, we know have tremendously high rates of thoughts of self-harm. So, we have to do better and know better to help these folks.
So obviously this sets the groundwork for what we're going to talk about, which is the amazing paper that was released out of the JAMA yesterday that you and all the colleagues have been working on. So tell us about how you came to this paper and then all the details. Let's go.
Yes. Yeah. Well, patients tell us all the time these stories about how they feel dismissed or invalidated. And this term, like this sort of buzzy term, gaslighting, is thrown around a lot. And we really wanted to dive into like, what does that mean? And how is it important to patients' experiences? I think that the really important thing we wanted to do was center the patient experience through this whole study. So we looked at testimonials from patients to talk about sort of dismissive behaviors they've encountered and incorporated our own understanding of what patients had told us. We made a survey, and then we had Tight Lips, which is a wonderful advocacy organization, and the National Vulvodynia Association. We had officers from both those organizations look at our survey and say, like, yes, these are the concerns that we as patients feel need to be measured and addressed. And so then we administered that survey once we had revised it to patients that are coming to our clinic. Obviously, our clinic is very specialized. It's people who've seen, 3-4 people before and they haven't, figured out what's going on. So they have pretty significant vulvovaginal diseases when they come to us. And so that's a very narrow population, but it was a good population to start with in terms of learning what our patients are experiencing. It doesn't generalize to the broader population yet. And I think that's like the big next step.
Yeah, absolutely. And I think that's, some even for me, seeing all the patients that we do, we hear the same stuff over and over again. And every once in a while, I'm like, did someone really say that? But then now life's easy, right? Like sometimes I'm like, oh yeah, you were told your body's meant for pain and that you should be able to deal with it. Okay.
It's crazy. And I also think I've been talking about this study and some of the things we found. And I think in our circles, the just have a glass of wine is shorthand for the dismissive behavior because we all hear it so much and know that patients hear that so much. That is just oh yeah, they got told just to have a glass of wine, meaning they were just shuffled off so that the next patient could come in.
So you can have a glass of
relax. But, in talking to people outside of this study and outside of the sexual medicine community, they were like, wait, people say that? And it's, all the time.
It's actually secondary thing that, well, yeah, of course you were told to relax and have a, you talk to any PE and they're like, yeah, of course she was told to have a glass of wine, but right, outside of that.
And so but in order to draw attention to it, we have to measure it, right? You can't just say my patients say this all the time. And the numbers are powerful to say, over 40% of the patients who come to us were made to feel crazy at some point in their care is much more powerful than saying patients are often made to feel crazy, right? And it's having the numbers to back it up is huge.
Yeah. Well, let's talk about the numbers because you guys came up. You had some great statistics that really, demonstrated the huge amount of really testimonial injustice that we see with these patients. Right, the idea that we don't believe patients, that we don't feel that what they're telling is the truth, or maybe we don't think that what's happening to them is real.
Right. 23% of patients were told that this was related to them being too high strung or too uptight, that was the root of their problem, or that they had, just the problem was just relaxation. 41% of our patients were told that they just needed to relax. I think the thing that was really distracting to patients was being told that their exam was normal, even though they had significant pain during the exam. And it's true that you may not have visual findings on exam that are abnormal, but it's very different as a patient to hear when you're screaming and crying and intolerant of what everybody seems to be able to tolerate, which is just a path test. And then be told everything's normal, right? You're in your head, that can't be right. And I've been on that side as a patient and know how distressing it is. So, but yeah, 26% of patients who had significant pain during the exam were told that was normal. And that's incredibly distressing. Yeah. And so, and we also sort of ask people to rate their distress. If 0 is no distress and 10 is the worst distress you've ever experienced, being made to feel crazy was the most distressing to patients. And that's why we included that term gaslight in the title. It is a buzzy term. It is a term that people have a lot of strong feelings about. But being made to feel crazy, whether it's, I think a lot of times it's not malicious on the part of the healthcare provider. It's just not knowing. But it's still being made to feel crazy. It's a distressing experience.
It's based in sort of the historical, misogyny, patriarchy, whatever you want to call it, that is women's healthcare, right? Hysteria.
It's healthcare, but this project has really made me reflect on our medical education, which you and I went to the same place, and I thought it was phenomenal. But I think back to this idea that every single note we write inherently doubts the patient's account. Yeah, it's crazy that every sentence starts with the patient reports, the patient notes. It's well, if the patient reports significant pain, why don't we say the patient experiences significant pain? Coming from this inherent place of doubt It's
Yeah.
like it colors, I think, sometimes the relationship that people have. And I try to like change my own language because it is a
Yeah.
mind shift. Like if that's
Totally.
this, what they're saying, then that's what like. Why? Most people aren't making
Yeah.
it up.
Yeah,
It's not
exactly.
Dr. House where everyone's lying. Like that's another like problematic, kind of like default.
Right. If you go into like just even the language we use with women versus men or women of color versus, white women. I mean, just
Absolutely.
calling a black woman non-compliant, or it's just like, oh, well, she's just non-compliant because she won't take her, medication versus like, let's try to understand what's happening, like why she maybe chose not to, or maybe you didn't tell her about the side effect. There's so much into that, but it's really, it's patient blaming for their own, it's
too. Yeah.
it's very negative, actually. I don't like it. And it's hard to get yourself out of that when you've been trained in this system, right?
Yeah.
Like it's like, not to say like it's just patriarchy, because matriarchy supports patriarchy, right? Like
right. It's all tangled.
Yeah, we are women in this profession and we were trained under this manner. So,
I think back to interactions I've had with patients when I didn't know as much about these conditions and things that I, probably missed. So, I think about this stuff in relation to myself and, I know better, do better. I'm trying to do better going forward, but I know I have fallen short in this way.
Yeah, I think we all have. And I think it's, it's a matter of not knowing. We didn't have the clinical knowledge because we didn't do the research.
Right.
And then being like, not being reflective on it either. So.
Right. Agreed completely.
Let's talk about sort of the stratification of, because speaking as a woman of color, like it seems like, the majority of the patients that were surveyed and maybe you guys reached out to a lot, but it's hard to get like a full, grades, diverse population.
Yeah, it's not a broad sample. It's not as broad as it could be. And it's because, our practice, has a more narrow, some of the demographics are more narrow. I think that, we tried to be very upfront about those limitations in the paper and say, like, this is really a hypothesis generating thing. We're trying to make this instrument, apply it to get everybody's attention about these numbers, but also say, like, these numbers aren't definitive. We really need to apply it in a much broader context.
Yes.
So that we have the like broad representation of lots of demographic groups. Because, and I said when I was writing this paper, I was like, this is a huge limitation. But if you think about it, it probably means if we have communities that are, especially socioeconomically, our population is less diverse. Like if you include people who are in more marginalized communities, my guess is these numbers are going to go up. I don't think they're going to go down. Like, I don't think we're sensationalizing this. It is true that our patient population is not in good shape from a medical standpoint. They have the harder conditions. And so maybe it's more likely that they would experience some of these behaviors. But I think also like the socioeconomic privilege piece of that is missing. And we have to figure that out.
Yeah.
Yeah.
I think this is such an important like first step in trying to really, qualify and quantify what's happening to these patients and these experiences. And we were just talking offline that like when I texted you last night, I was like, my husband just told me that Reddit was exploding right now because someone posted it. And it was amazing, actually, right? It was like, thousands of women telling their same stories.
Yeah. And I try to do Reddit like a couple hours a week just as like community service, answering OBGYN questions and like being part of the community, because that is where so many people get their information about medical care, and there are not as many qualified voices on there as there need to be. So come on down and jump on in because the water is a little choppy, but they need us there.
Yeah, that's what I told myself yesterday. I was like, I'm going to be a little bit more involved in Reddit. And so what from here? Like, what is the next step, do you think, for this?
Yeah, I mean, I think there are two really like mandates that I take from this. One is we need to repeat the survey and validate it to show that it's like statistically a reasonable thing to use. And that way we can use it in lots of populations. I also think it's made in such a way that it can be applied to different problems, right? Like endometriosis, pelvic pain. It can be used in different patient populations, different disease populations, and different settings if we do the work to kind of validate it from a statistical standpoint. And then the other thing that we need to do is, the main theme in the representative quotations in this paper was how there was a lack of training and understanding in the medical community. And so we need to educate people on vulvovaginal conditions so that they understand the differential doesn't stop. The list of possibilities doesn't stop with a bacterial infection or a yeast infection, right? There's so much more that can happen to the vulva and the vagina than those two things. And if we stop our training at those two things, then we are doing a disservice to the healthcare providers who then won't, know how to handle the patients that come to them, and to the patients who won't get the help they need.
Absolutely. And I think that's why some of these patient advocacy groups are so important. I know I've had Tight-Lipped on the podcast before too, but just working with them and trying to do lectures for, different residencies, that's really important. They're doing a lot of work. We're doing the work at Ishwish, trying to get more and more clinicians trained in this. And, whatever way we can, right? Like we have to just get the information out so that, again, this is, if you graduated like me, like so 20 years ago, like you didn't know any of this because, this is not taught. And so this data and this understanding and, region-based approach and vestibulodynia and all the terms that we throw around on this podcast are new. They're like in the last, 10 to 14 years probably, right?
Well, like we had a wonderful vulvar specialist that I really learned a lot from in my residency program. It wasn't like we had no training, but my time with her was extremely limited. And I spent so much time on those life and death things, which are really important to know in training. The obstetrics and gynecologic oncology parts of OBGYN residency are robust because those are the places where they need all hands on deck to care for people in the hospital. And it teaches you sick and not sick. It doesn't teach the bread and butter and the things that affect most people more often.
Yeah. So I think, those of us, that are associated or close to academics, we have to kind of get that information out there and allow students to rotate with us and residents. And I know you guys do that as well. So
yeah, we do. Anyone can come hang out with us that wants. Come on down.
So, yeah, come on down. Exactly. And so, I think so the next steps are that, and then just continue to educate, right?
Yes, agreed completely.
And the other interesting thing in the study was how many patients almost decided to give up on their journey, right?
Yes. And again, that's a thing where I feel like the skew, and we wrote about this in the paper, like in my heart, I believe that I think it's 56 or 54% of people who said they almost gave up on care would be a lot higher if we could start at the beginning of people's journeys and follow them prospectively with vulvovaginal conditions. Because I think we lost people who, in fact, did give up care. I think if 56% of people tell you they were thinking about giving up care, your number's higher because the people who did give up care are not represented in your sample. So I think that number's higher. So it speaks to the fact that our education and our sensitivity to this is so important because we're losing people who really need care, and it may have profound effects on their life. There was a quote by a patient in here who talks about how they had given up care years before and lost so much of what they felt like should have been part of their life because of it. Didn't pursue a long-term relationship, didn't pursue having kids and a family in the way that they wanted because they just thought this was not something they could get help for.
Yeah, absolutely. I mean, I think it really colors their life. And I feel like, people don't reach certain potentials and goals that they want in life, or even quality of life is just ruined for so many people. And so it's so important for, us to really be on top of this. And I find like a lot of times, like if I'll have someone that has, say, like, hypertonic pelvic floor in the form of like vaginismus, where they've never had any penetration for years and years and years. And many times they'll come to me and they're ready for treatment, but they're not ready to do the steps for the treatment. Like you have to do the PT, you got to do the dilators, you got to do the boat, you got to do all the things. And it's time consuming, right? Like some of these people are high executives, they're working, they're in school, they're in med school. I have a lot of, medical people that do this, and where do you make time for? So then years and years just pass. And at some point you just resolve that maybe you're not going to have penetration or, have Yeah.
Yeah.
And
Or you'll
so,
go a different route in terms of making your family. I mean,
yes.
yeah. But those same folks, if we could have caught them earlier, because we know things like if you catch LS before they're having scarring, then they're not going to have the pelvic floor dysfunction and they're not going to have all these other downstream effects. Then
Yes.
you save people all the work that they'll then have to do at the back end if you can catch them early. And so we just, have to do better.
So true. So it's really about early diagnosis, early intervention, and finding the right people. And we always talk about, so what do you tell people that ask you, like, how can I find someone to help me, or what do I do to advocate for me? Right? Because that's one of my biggest things is like really learning how to advocate for yourself. And you're here and you think that you're being dismissed. Like, what do you tell patients about that? Because we've both been
I do this. I have like a standard thing I do on Reddit a lot because those patients aren't necessarily patients that can come to see me or they may be out of the country. And so I refer people to a couple of kind of standard resources. I usually say, hey, the book When Sex Hurts is something that I read, before I even knew Andrew.
Yes.
Because I thought it was great for patients or for clinicians. So I think that's a great recommendation, whether you're a doctor treating these patients or you're a patient who needs help, to give everybody sort of a shared mental map of the anatomy and the possibilities, at least as we understand them now. And those proceeds go to the National Vulvodynia Association. So I think it's just like a win-win. And then the National Vulvodynia Association, Tight-Lipped, are great organizations where they have, resources to find a clinician near you. And then ISHWISH and our website has some good resources too, vulvodynia.com.
Right.
Yeah, that's a great resource. Yeah.
All right. Awesome. Well, thank you, Chailee, for coming on last minute. I was texting her last night. I was like, let's just get on there and talk about it.
Let's do it. Express. Let's do it.
The information out there so people can read about it, feel validated. But, I think, but the other thing is I feel like a lot of patients are just pissed off too, right? Like they're just so angry about it because they've been traumatized so much by the medical system.
Yeah.
That it's really hard for them to like I even notice sometimes sometimes the first visit is very triggering for them, right? Because they're always, they have their whole.
And I think I see that a lot on Reddit. I see it a lot in online circles, but I don't think clinicians get it because they're not in those communities to really understand the simmering rage around these kinds of things. And so I feel like this is in some small way our way of saying, look, you may not realize that you're unintentionally causing this harm, but it is being caused. And we really need to be aware of how our language and our attention to patients is being perceived.
Absolutely. Well, I think that's a great way to end it. And, all this is going to be in the show notes. The article and its information is going to be in the show notes as well. So you guys should check it out and read the article. It's amazing that we have some, validated information that, we all knew, but unfortunately it's truer than we imagined.
Yeah, more work to do, but thank you so much for bringing attention to the article.
Absolutely. Thank you, Chailee. I appreciate you being here. You guys will see in the show notes where you can get in touch with her if you need to see her or, compliment her for her amazing work. Whatever you want to do. I'm Dr. Sameena Rahman, Gyno Girl. Thanks for coming to another episode of Gyno Girl Presents Sex, Drugs, and Hormones. Remember, I'm here to educate so you could advocate for yourself. Please join me on another episode in a second. Please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear to get more information. My practice website is www.cgcchicago.com. My website for Gyno Girl is www.gynogirltv.com. My Instagram is Gyno Girl, so please follow me for some good content. Additionally, I have a YouTube channel, Gyno Girl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, Gyno Girl News, which will be available on my website. I will see you next time.